Welcome to the Deep Dive. Today we're tackling a really critical topic in medicine, how we prevent pulmonary embolisms, PEs, using something called Vena Cava interruption techniques.
That's right. And it's fascinating to look back at how this has evolved.
Yeah, we've got quite a journey ahead looking at everything from some, well, pretty bold early surgical ideas right through to the sophisticated devices we use now.
Absolutely. Our sources show that back in the 50s and 60s, the thinking was often quite direct. Surgeons were actually tying off major veins, the femoral vein, even the inferior vena cava itself sometimes.
Wow, tying off the IVC.
Yeah, or using clips, staples, trying to partially block it to catch clots heading towards the lungs.
Okay, hang on. So tying off a major vein like the IVC sounds incredibly drastic. What were the actual outcomes?
Well, yeah, it was drastic, and often it didn't work out so well. These methods frequently led to complete blockage of the vena cava.
Which causes...
Major problems with blood flow returning from the legs. Swelling, pain, long-term issues. And maybe the most surprising part, the data didn't really show a big improvement in preventing those fatal PEs.
Huh. So a lot of risk, a lot of potential harm, without a clear win against the deadliest outcome.
Exactly. It highlighted the need for a better approach.
Okay, so those early attempts, innovative for their time maybe, but serious drawbacks. Now, this is where our sources say things started to really shift. 1967, the Malbin-Uden umbrella filter. This was one of the first devices put inside the vessel, right? Less invasive.
Right, a huge leap conceptually. It could be inserted through a vein, often in the arm or leg, which was much less invasive than open surgery. It was basically a silicone membrane, kind of like an umbrella, with a small hole for blood flow.
Okay, sounds promising, but...
It had a major flaw. It turned out to be quite thrombogenic itself.
Meaning it caused clots to form on the filter.
Precisely. So you'd often end up with the vena cava getting blocked anyway because of clots forming right there on the device. A step forward in delivery, but a big step back in terms of complications.
It really sounds like a pattern. Solve one problem, uncover another.
Right.
Okay, so then 1973 rolls around, and we get the stainless steel Greenfield filter. Our material really stresses this one became the benchmark. Why was it such a game changer?
It really was. The Greenfield filter, the original stainless steel one, just had a much better design. It struck a more effective balance between actually trapping the dangerous clots and allowing blood to flow through relatively unimpeded.
Better fluid dynamics?
Exactly. And then later versions came out titanium in '89, which was a big plus for MRI compatibility, and lower profile steel ones in '95 that were easier to insert. Because it was around for so long and studied so much, it just became the standard everyone compared new filters to.
Right. So for this deep dive today, our mission, you could say, is to really get under the hood of these IVC filters. We want to explore, how they're designed, the different kinds out there, the thinking behind when to use them, how they're put in, and really importantly, how and when they come out.
Exactly. And the field hasn't stood still. We've seen retrievable filters become common ones you can take out later, and even newer ideas like convertible filters that can sort of switch off their filtering function.
Fascinating.
Yeah, the goals are always pushing towards easier deployment, better clot trapping, maintaining blood flow, and making retrieval safer and more predictable.
Okay, let's start right there with the design. What's the absolute core function? How do they actually stop a PE?
Fundamentally, it's pretty simple. They act like a sieve or a net placed inside the inferior vena cava, that's the big vein bringing blood back from your lower body. The idea is to catch any large blood clots, thromboemboli, that break off from, say, the legs before they can travel up and block arteries in the lungs.
Like a safety net. Makes sense. But designing that net must be complex. What makes a filter design good? What are the ideal features?
There's a long list. Ideally, the material itself needs to be non-thrombogenic, doesn't cause clots. Biocompatible, the body accepts it. Non-ferromagnetic is important for MRIs down the line. And, obviously, it needs to be durable.
Okay, the material's key. What about the shape and function?
Functionally, you want high filtering efficiency catches the bad stuff, but without significantly impeding blood flow. Too much blockage is bad. Generally, designs with a single trapping level and a conical or cone shape are favored. They seem to offer the best filtering to flow ratio.
Conical. Like an ice cream cone shape, almost. Why is that specific shape so good?
Yeah, pretty much. Think of the Greenfield filter again. That cone shape is really clever. It can trap quite a lot of clot, filling up maybe 70% of the cone's volume, which is about 4 cubic centimeters, while reducing the area for blood flow by less than half.
So it can hold a fair bit before blocking things up.
Right. Flow only really drops off significantly once it's more than, say, 80% full. It lets the blood flow around the trapped clot quite effectively, up to a point.
That's smart. Now, our sources also mention other designs, maybe with double layers or basket shapes. What's the thinking there, and what are the downsides?
Well, the idea behind those is maybe they're better at catching really tiny emboli. But the trade-off is they tend to disrupt the blood flow more turbulence, slower flow, and that can actually increase the risk of the vena cava itself clotting off, so potentially higher occlusion rates compared to the simpler conical designs.
Okay, another trade-off. Now, what about these retrievable filters? There must be really tricky balance there. They need to stay put, but not too put, right?
Exactly. It's a critical design challenge. Permanent filters, you want them to integrate quickly and firmly into the vessel wall incorporation to stop them moving. But retrievable or optional filters need just enough grip to stay in place and catch clots, but without embedding so deeply that you can't get them out later.
And messing with the anchors to make retrieval easier could cause other problems.
Precisely. If you change the hook design, maybe make it less aggressive to ease retrieval, you might inadvertently increase the risk of the hooks digging too deep into the IVC wall penetration, or even the whole filter migrating.
So different manufacturers probably have different solutions for the hooks.
Oh, definitely. The original Greenfield used these recurved hooks, designed to engage the wall at a specific angle, around 80 degrees, for good fixation without fully piercing through. Newer filters designed for retrievability, like the Select Platinum or Denali, use different hook shapes and angles aimed specifically at minimizing that deep embedding.
Are hooks the only way they stay in place?
Not always. Some filters, like the Venatech LP or the Optis, rely less on sharp legs or hooks for their initial stability, using other points of contact or radial force, which can potentially reduce that risk of penetration.
Okay, and keeping the filter centered in the vein. Is that important?
Yes, staying centered helps maintain optimal blood flow through the filter and ensures it's covering the vessel lumen effectively. Some designs, like Denali and Select Platinum again, have features specifically designed to help them self-center.
Makes sense.
Others, like Venatech LP and Optis, use multiple contact points with the IVC wall for stability, but again, trade-offs. More contact points might help centering, but they don't necessarily increase clot capacity and could theoretically increase the risk of those contact points, causing issues like penetration or even contributing to clot formation over the long term.
Wow, okay. It's a world of really fine-tuned engineering compromises. Let's shift gears now and talk about the main types of filters our sources categorize.
Sure. Broadly, you can think of them in four main groups. First, permanent filters. These are designed for lifelong implantation. Fixation is maximized. Second, optional filters, often called retrievable filters. These can function permanently if needed, but they're designed with the option of being removed, usually within a specific time window. They use things like hooks, barbs, or just outward pressure to stay put temporarily.
Got it. Third,
Temporary filters. These are not meant for permanent placement. They're actually attached to a wire or catheter that stays outside the body, allowing removal right at the bedside once the high-risk period is over.
and the last one.
Finally, the newer category, convertible filters. These go in looking like a permanent filter, but they have a mechanism that allows them to be changed or converted into a non-filtering state later on without necessarily removing the whole structure.
Okay. And for today, we're mostly focusing on.
We'll mainly talk about the FDA-approved permanent and the optional retrievable types, as those are the most common in clinical practice.
Well, convertible ones sound really innovative, though. How do they work?
Yeah, they're quite interesting. Take the Venatech convertible. It goes in as a standard filter, but if it's decided later that filtration isn't needed long-term, they can do another minimally invasive procedure, go back in, and basically remove the central filtering cone part, leaving the anchoring legs behind.
So it becomes like an open frame.
Essentially, yeah. Then there's the Sentry filter, which is even more unique. It uses a nisinol frame, but holds its shape with a special bioabsorbable filament.
Bioabsorbable, meaning it dissolves.
Exactly. Over about 60 days or so, this filament dissolves through hydrolysis. As it dissolves, the filter arms spontaneously retract back against the IVC wall. So it bioconverts itself to an open lumen state without needing a second procedure.
That is pretty neat engineering.
Yeah.
And the temporary ones, where do they fit in?
Temporary filters, like the Mermaid Angel catheter, are really for very short-term, high-risk situations, often in the ICU. The Angel filter is actually attached to the end of a central line catheter.
So it does double duty.
Right. You get your central venous access for meds and monitoring, and you get PE protection. It's placed and removed at the bedside. It's a conical nitinol filter that expands inside the IVC. Because it's attached, retrieval is straightforward when it's no longer needed.
Very practical for critical care. Okay, now we have to talk about the less positive side, the complications associated with these filters. Our sources mention it's been hard to compare data historically.
That's been a real issue. Different studies use different definitions for complications, making direct comparisons tricky. This led to published guidelines calling for standardized reporting.
Makes sense. So what are the main complications we need to be aware of?
Well, key ones include filter migration or embolization. That's when the filter moves more than 2 centimeters. Thrombotic occlusion, where the filter itself clogs off, either primarily or due to trapped clot. Filter tilt, if it tilts more than about 15 degrees, it might not work as well. Filter perforation, where a strut or hook pokes more than 3 millimeters through the IBC wall. And filter fracture, meaning part of the filter actually breaks.
Those all sound serious. What kind of rates are we talking about?
The numbers vary quite a bit in the literature depending on the filter, how long it's in the patient group. But generally, you might still see PE occur in maybe 2–5% of patients with a filter. Fatal PE is rarer, maybe 0.7%. Death from the insertion procedure itself is very low, around 0.12%.
Okay. What about other issues?
Access site thrombosis, clots where they put the catheter in, can range from 2% up to nearly 30% in some studies. Migration rates reported are anywhere from 3% to nearly 70%, huge range there. Penetration of the IVC wall, maybe 9–24%. Obstruction or blockage of the IVC, 6–30%. Long-term leg swelling or venous insufficiency, 5–59%. Fracture is relatively low, around 1%. And getting a guide wire tangled in the filter during placement or retrieval happens in about 1% of cases.
That migration range is huge, and penetration seems like a growing concern.
It does seem to be reported more often. One big review found an overall penetration rate of 19%, and in about 8% of those cases, it was causing symptoms and needed intervention.
So the takeaway seems to be that while most filters do a decent job preventing PE, they come with their own baggage, and the complication profiles might differ between designs.
That's a fair summary. The primary job, PE prevention, is usually achieved, but the secondary effects, the complications, definitely vary and are a major factor in choosing if and which filter to use.
Which brings us squarely to comparing permanent versus these optional retrievable filters. Our sources say while they protect against PE, a clear survival benefit isn't always there.
That's a really important nuance. Filters are proven to reduce PE risk in high-risk scenarios, especially when anticoagulation isn't possible, but whether that translates to living longer overall is less clear from the data we have. You're always balancing the filter's benefit against its potential long-term risks.
And the big trial for permanent filters, PREPIC, what did that show?
Right, the PREPIC trial is key here. It found that permanent filters did lower the rate of PE in the first couple of weeks, but importantly, they also led to more DVT, more deep vein thrombosis down the road at 2 years.
More clots in the legs.
Exactly, and the 8-year follow-up confirmed this: fewer initial PEs, but more DVTs later, with no difference in long-term survival or post-thrombotic syndrome. So the conclusion is basically that routine use of permanent filters for everyone with VTE probably isn't warranted.
Okay, that's crucial context. Then PREPIC 2 looked specifically at retrievable filters.
Yes. PREPIC 2 compared adding a retrievable filter to standard anticoagulation versus anticoagulation alone in patients with acute PE. The result: adding the filter didn't significantly reduce recurrent symptomatic PE at 3 months.
So it didn't support routinely adding a filter if the patient can take blood thinners.
Correct. It really questioned the benefit in that large group of patients, where retrievable filters fit in for patients who can't take anticoagulants or have only DVT or other specific situations. That's still less clear.
It's interesting, our sources note this big boom in filter use in the U.S., followed by a decline, sort of mirroring the rise of these optional filters.
There definitely seems to be a correlation. The availability of optional filters likely contributed to wider use, maybe sometimes prophylactically. But that wider use also meant more potential complications being seen over the long term.
Which led to the FDA getting involved.
Exactly. The FDA issued safety communications in 2010 and 2014. They highlighted concerns based on adverse event reports, things like filters migrating, breaking, perforating the vena cava, especially when these retrievable filters were left in long term.
And the recommendation was?
Pretty clear. Get retrievable filters out as soon as the PE risk drops and the risk-benefit balance favors removal. They also mandated more studies, like the ongoing PRESERVE trial, to gather better long-term safety data.
But when to take them out seems tricky. The manufacturers give different time frames.
That's a real practical challenge. Some filters have specific recommendations, like the Gunther Tulip often cited as within 20 days, Opti's within 14 days. Others, like Select, have a much longer window, up to a year, and for some, it's not clearly specified.
Can they be retrieved after those windows?
Sometimes, yes. There are case reports of successful late retrievals, but the data shows success rates drop sharply over time. One review found like 99% success at 1 month, down to 94% at 3 months, but only maybe 37% success by 12 months.
Wow, a big drop.
Yeah, it suggests that for most optional filters, the best window for retrieval is probably within the first few months. The longer they stay in, the harder and riskier retrieval becomes.
So bottom line, optional filters are not permanent replacements if lifelong protection is truly needed.
Absolutely not. Optional filters make sense when 1. There's no permanent indication. 2. The immediate PE risk is high but expected to resolve. 3. The patient isn't likely to go back into a high-risk state. 4. They'll live long enough to benefit from removal. And 5. Removal or conversion is actually feasible and safe.
Okay, that clarifies the distinction. Let's talk clinical decision-making. When should filters be used? What do major guidelines like ACCP or ASH say?
Generally, the big guidelines advise against routine prophylactic use, meaning don't put them in just in case if the patient isn't high risk or can take anticoagulants. The main indication is really for patients with proven VTE, DVT, or PE who have an absolute contraindication to anticoagulation, or maybe who had a major bleeding complication on anticoagulants, or possibly recurrent PE despite adequate anticoagulation, though that's rarer.
And they stress resuming blood thinners ASAP.
Always. Filters stop clots from reaching the lungs, but they don't stop clots from forming in the legs. Anticoagulation is key for treating the underlying DVT.
What about those relative indications where the evidence is maybe less strong?
Right, there's a gray area. Situations like poor compliance with blood thinners, maybe a large free-floating clot seen on imaging, certain cancers invading veins during clot-busting procedures, thrombolysis, patients with DVT but very poor heart-lung function.
So situations where the consequences of even a small PE would be devastating.
Exactly. Or maybe recurrent PE causing pulmonary hypertension, DVT in specific high-risk groups like cancer or burn patients or pregnancy. Prophylaxis is sometimes considered in very high-risk surgery or trauma too, but again, evidence is debated. More recent guidelines try to give more specific scenario-based advice.
Let's dive into some of those specific patient groups. Trauma patients, high risk, often can't get anticoagulants right away. What's the approach?
Trauma is complex. High VTE risk, absolutely. Standard care is anticoagulation if possible, or mechanical compression if not. Prophylactic filters have been debated for years in those high-risk trauma patients who can't get blood thinners initially.
But routine use isn't recommended.
Generally, no. Early guidelines allowed for selective use in very high-risk cases with prolonged immobility. But a key recent randomized trial, high-level evidence, found that putting filters in prophylactically within 72 hours didn't actually reduce deaths or symptomatic PE overall in patients with contraindications to anticoagulation.
Interesting. No overall benefit.
Not overall in that study, though there was a hint it might help a subgroup who couldn't get anticoagulated long-term. So the current thinking for trauma is really filters for documented VTE if anticoagulation is impossible, or maybe very selective prophylaxis only if the VTE risk is deemed extremely high and outweighs the filter risks.
Okay. What about bariatric surgery patients? Obesity is a big risk factor.
Yes, and PE is a major worry after bariatric surgery. You have the risk from obesity itself, plus the surgery, plus challenges sometimes in dosing anticoagulants correctly. This led to some use of prophylactic filters, trying to identify the highest risk patients.
Did it help?
Some small studies suggested filters might bring the PE risk in high-risk bariatric patients down closer to the baseline low-risk level. Using retrievable filters just for the high-risk perioperative period has also been tried, with low PE rates in small series. But the overall evidence is pretty weak. Small studies, no good controls, lots of variability. A systematic review basically said there's no clear proof the benefits outweigh the risks right now. We need better trials.
Okay. Orthopedic surgery like hip or knee replacements? Also high VTE risk.
Definitely. And filters have been studied here too. Optional retrievable filters seem like they could be useful for temporary protection post-op. But again, not much high-quality randomized data. Current guidelines mostly say filters only if there's documented VTE and a contraindication or complication from anticoagulation, not for routine prophylaxis.
Cancer patients are another tough group. High VTE risk inherently.
Yes, cancer itself drives up VTE risk. There's debate here, too. Some argue filters might be a reasonable alternative to long-term anticoagulation in selected patients with decent quality of life, maybe if bleeding risk is very high, perhaps even less costly than managing bleeds.
But do filters work as well as primary therapy?
That's the question. Some studies show more VTE events, PE, recurrent DVT, IVC clots when filters are used instead of anticoagulation as the main treatment in cancer. One registry study showed no mortality or recurrent PE benefit, but increased DVT risk with filters.
So the recommendation now.
Generally, reserve filters for cancer patients with documented VTE who can't take anticoagulants or had major issues with them, and who have a reasonable expected survival. Discouraged in very advanced disease with poor prognosis.
What about high-risk general surgery or pregnancy? Briefly.
For general surgery, VTE risk is real without prophylaxis, but the benefit of routine filters over anticoagulation risks isn't well established. Use isn't widespread. For pregnant patients, indications are similar: documented VTE and issues with anticoagulation. Anticoagulants might be stopped around delivery. Optional filters can be used temporarily, maybe for recent proximal DVT or large PE, with planned removal postpartum. Studies suggest they're effective and can reduce maternal mortality in these high-risk cases. Positioning might need adjustment, often suprarenal placement due to the uterus compressing the lower IVC. Jugular access might be preferred, but suprarenal optional filters might have a slightly higher migration risk.
Okay, lots of clinical nuances there. Let's shift to the placement and retrieval procedures. Anatomy must be key here.
Absolutely crucial. You need to know the normal IVC segments, hepatic, suprarenal, renal, infrarenal, and where the renal veins typically drain, usually around the L1, L2 vertebrae. But just as important is knowing the common variations.
Variations like what?
Things like multiple renal veins or the left renal vein looping behind or around the aorta that happens in maybe 5–7% of people. You need to spot that to avoid trapping a filter leg or causing tilt.
Okay, what else?
You can have IVC transposition where it's on the left side, maybe 0.5% of people, or IVC duplication, 2 IVCs right and left, maybe 0.3%, or even rarely IVC agenesis where the lower part is missing and blood finds other routes back, like through the azygos system.
So if someone has duplicated IVCs and a clot in the left leg?
You might need a filter in both IVCs, or perhaps a single filter placed higher up suprarenally after the left IVC joins the right to catch clots from that side. Careful imaging before the procedure is essential to map out the specific patient's anatomy.
Right. Now, the procedure itself, how successful and safe is it generally?
Technically, placement is successful almost all the time, like 98–100%. Acute complications related to the procedure are pretty low overall. Things like putting the filter in slightly the wrong spot, malpositioning, maybe 1.3%, a bruise or bleed at the access site, hematoma, 0.6%, air embolism, 0.2%, hitting an artery by mistake, 0.04%. Very rare things like AV fistula or lung puncture, pneumothorax are even lower.
Fatal complications.
Extremely rare, around but 0.13%. There was some older concern about a specific filter type, the bird's nest, maybe having a higher rate, but that was likely due to the patients being sicker to begin with.
You mentioned suprarenal placement sometimes. Is that riskier?
It might be. Some studies report higher rates of issues like kidney problems, recurrent PE, migration, fracture, or penetration with suprarenal filters. So it's usually reserved for specific situations where the PE risk is felt to be very high and warrants taking on those potential extra risks like clot extending up to the renal veins or IVC duplication or pregnancy.
Can these be placed at the bedside?
Yes, using ultrasound guidance, either transabdominal ultrasound through the belly wall or intravascular ultrasound IVUS inside the vein has proven safe and effective, especially when fluoroscopy isn't readily available or desirable. Technical success is high if you can see the landmarks well, though there might be slightly higher risk, maybe 2–3% of the filter being slightly malpositioned compared to fluoroscopy guidance. Techniques exist to fix that if needed.
Okay, let's quickly touch on the different guidance methods. Venography first, that's the standard.
Still considered the gold standard, yes. Using fluoroscopy, live X-ray, and injecting contrast dye to see the veins, usually access via femoral, jugular, or sometimes arm vein. Critically, you don't just rely on bony landmarks on the X-ray.
Why?
Because the position of renal veins relative to vertebrae can vary quite a bit. You need to do a venogram inject dye to see the actual veins, confirm landmarks like the lowest renal vein and where the iliac veins join, and and check for clot. Sometimes you need selective injections into specific veins if the overall picture isn't clear. Finding unexpected anatomy happens often enough, maybe 11–30% of cases, that it changes the plan.
And the ideal spot.
For standard infrarenal placement, you want the filter tip right at the level of the lowest renal vein and the base above where the iliac veins come together. For suprarenal, you need venography to define the renal veins below and the hepatic veins above, usually T11, L1 level. Make sure the IVC isn't too wide, usually 28 millimeter, and position the filter just above the highest renal vein but below the hepatic veins.
How does transabdominal ultrasound guidance compare?
It's non-invasive, done at the bedside. You use the ultrasound probe on the abdomen to find the IVC and the renal veins, often using the right renal vein and artery as landmarks. You watch the guide wire go in, then the sheath, then position the filter delivery catheter tip relative to the renal veins, often by seeing it reappear just behind the vein confluence in the long view. Then deploy the filter under direct ultrasound visualization and check its expansion and final position afterwards.
And IVUS intravascular ultrasound.
That uses a tiny ultrasound probe on a catheter inside the vein, usually femoral access. You would advance the probe up to the heart and pull back slowly, identifying landmarks from the inside. Right, atrium, hepatic veins, renal veins, iliac confluence. You measure the IVC diameter directly. You can use single access if the delivery sheath is big enough, or dual access, one for IVUS, one for the filter if needed. You watch the sheath or catheter tip align with the lowest renal vein on the IVUS image during deployment, then check the filter legs are nicely against the wall afterwards. Usually get a plain x-ray afterwards too, just to confirm position.
That covers placement really well. Now, retrieval, getting those optional filters out. Timing is key, you said.
Absolutely. You want to retrieve when PE risk is low, anticoagulation can restart safely, and retrieval itself is likely to be safe and uncomplicated. We know that active follow-up programs educating patients, tracking filters, dedicated clinics, teamwork are much better at getting filters retrieved in time than just hoping patients come back.
What happens before retrieval?
Usually get an x-ray to check the filter hasn't broken or moved wildly, then often a venogram right before trying retrieval to make sure there isn't a large clot trapped inside. If there is, you might leave the filter in.
And the technique?
Most are removed using snares on catheters, grabbing a hook or feature designed for retrieval. The exact tool varies by filter type. Sometimes they're stuck incorporated into the wall. If it doesn't release with gentle pulling, you usually stop to avoid damage.
What makes retrieval difficult?
Pre-retrieval CT scans might show predictors like struts embedded in the wall, severe tilt, perforation, or just having been in for a very long time. For those tough cases, there are advanced tricks. Using special loops or catheters, ballooning the IVC slightly, using tiny forceps like those used in bronchoscopy, or even laser sheaths to carefully free up tissue ingrowth. But the longer it's in, the harder it generally gets.
And briefly, placement for convertible and temporary filters.
Convertible ones like Venatech or Sentry have specific deployment steps, and Venatech needs that second procedure for conversion. Sentry converts on its own. Temporary ones like the Angel catheter are designed for simple bedside insertion and removal because they're attached to that central line.
Okay, one last area our sources cover. Filters in the Superior Vena Cava, the SVC, for clots from the arms or upper body.
Exactly. Upper extremity DVT is seen more now, often related to central lines, pacemakers, malignancy, etc. And these clots can cause PE, maybe 5–10% risk, some reports higher, even fatal PEs.
Same treatment?
Standard treatment is still anticoagulation, but SVC filters are an option if anticoagulation is contraindicated or fails. The data is much more limited than for IVC filters, mostly case reports, small series, animal studies.
Are they different filters?
Not really specific SVC designs yet. Usually, standard conical IVC filters, often the Greenfield permanent type historically, are adapted for SVC use, though optional filter use and retrieval in the SVC has been reported too.
Placement considerations.
Access via jugular or femoral. Interestingly, you often use the opposite approach for orientation, like jugular access for a filter designed for femoral insertion. Need detailed venography to map the SVC anatomy, check for duplication, rare but possible, look for clot. Ideal position is just below where the innominate veins join. Need to measure SVC diameter, again, usually 28 millimeter. Complications are possible: malpositioning, perforation, tamponade, thrombosis, interaction with central lines. The largest series reported low complication rates related to the filter itself, but overall mortality was high due to the patient's underlying conditions.
So a potential option in select cases, but based on limited evidence.
That's right. appears relatively safe and effective for preventing PE from upper extremity DVT when anticoagulation isn't an option, but needs careful patient selection and awareness of potential issues.
Okay, let's try and wrap this up. What are the big takeaways from this really detailed deep dive into vena cava interruption?
Well, I think the main point is that IVC filters are definitely an important tool we have for preventing PE, but they're best reserved for specific situations, primarily when anticoagulation, the standard treatment, just isn't possible or has caused major problems.
There's a whole range of designs now.
Exactly. Permanent, optional retrievable, temporary, convertible. Each has its own pros and cons, its own indications, its own set of potential complications. Understanding those differences, the nuances of design, the placement techniques, the retrieval challenges, it's all critical for choosing the right approach for the right patient.
It's definitely clear this is a field that's still evolving. You mentioned ongoing research, guidelines changing.
Absolutely. Studies like PRESERVE are still collecting data that will help us better understand long-term outcomes, especially for the retrievable filters, and hopefully refine who benefits most and when retrieval is optimal. The technology keeps improving too.
Right. So maybe a final thought for you, our listener, to consider. With all these advances in retrievable filters and this big push now for timely removal, what do you think the future holds for the traditional permanent IVC filter? Will its role shrink significantly in the years ahead?
That's a really interesting question to ponder. It definitely highlights the dynamic nature of this field.
Indeed. If you want to explore this further, definitely check out the research we've drawn on or talk to medical professionals for specific advice. Thanks so much for joining us for this deep dive.
My pleasure. It was a great discussion.